It is now my pleasure to introduce you to Lois Sadler. And this is actually, as I thought about this, Lois and I have known each other longer than we care to count. I was an instructor at the Yale University School of Nursing, and I graduated from here in '76 and was an instructor while I was working at Yale New Haven Hospital and developing the pediatric diabetes program there. And so Lois was a student of mine. I don't remember whether I taught her anything, but I do remember. And then we worked together in a lot around adolescent issues. So it is really quite a pleasure for me to introduce Lois to you. She's a professor here at the School of Nursing and at the Yale Child Study Center. She received her BSN, magna cum laude, from the University of Massachusetts, her MSN from here in 1979, and her PhD from the School of Family Studies at the University of Connecticut. Dr. Sadler is also a certified family life educator and practices as a pediatric nurse practitioner at the Polly McCabe School, a special school here in New Haven for pregnant and parenting students. In her faculty role here at Yale, she teaches everybody master's, doctoral, and postdoctoral fellows in the area of family studies, child development, pediatric health promotion, research, and research ethics. Her research is focused in the areas of the transition to parenthood among urban adolescent mothers. We're on a diversity theme right now, but look, that'll switch later. And their families, adolescent pregnancy prevention, evaluation of specialized school-based support programs for adolescent parents, home visiting interventions for at-risk young families, and community-engaged research methods and ethics. She's principal investigator of the community-based interprofessional Minding the Baby home visitation program for vulnerable young families, currently in the final stages of efficacy testing and supported by NICHD funding. Her work with colleagues from the Minding the Baby has been translated and is currently being replicated with complex young families living in 3 urban communities in the United Kingdom, sponsored by the National Society for the Prevention of Cruelty to Children. Oops. How do I get to the next one there? So her talk is entitled Reflections on a Reflective Parenting Home Visiting Program. Lois.
Okay, great. So thanks, Margaret. I'm really happy to be here today, and in these reflections, what I'm going to try and do is tell you the story of where we've been, what we've learned, and some of the future directions that we're going in as we have developed and implemented this home visiting program for very young, very highly stressed families who are learning to raise their first baby. I'll talk about some of the training initiatives we're involved in, some of our future research ideas and directions, and some of our business planning as we begin to make the transition from a research protocol into hopefully a sustainable model for this program. This is really a wonderful community-engaged research endeavor as well as a clinical program that we have developed. And so here are some of our collaborating partners. And obviously this always takes a team to do this kind of work, especially in community work. And what I've tried to do as we go through the slides is I will highlight in blue all of the YSN alums, and I hope I haven't missed anyone, but there's quite a few students, former students, faculty members who are part of our team and have contributed greatly to this work. So this really started a number of years ago when community members and practicing clinicians at the Fairhaven Community Health Center, which is a health center that serves a particular neighborhood in New Haven, came to some of us who were known to them in terms of our clinical practice and our research, came to us and said, you know, we're really worried about our families, our very young families. We know they need more support, more service than what we can give them as they come in for their primary care visits, their prenatal visits, their well child visits. They need more. They're under a tremendous amount of stress. And we see the outcomes when we can't give them the support that they need. We see the children who are suffering. We see mothers who have a variety of mental health and ongoing health problems. And we just need to think of something that will be more innovative and more responsive to the community's needs. And this came from community members as well as clinicians. And so what we did was we got together and we took about a year to plan this whole process. We did a needs assessment. We worked together with our colleagues. So the university and the community colleagues worked very closely together to come up with a program that would both sort of cement this collaborative, trusting relationship that we've started to work on, met the needs of the community, and would assure that we were providing consistent care, both in our new program and the care that the patients were already receiving at their health center. And from the very beginning, we insisted that there needed to be a rigorous evaluation component, research component as part of this program. So as a result of that work, we came up with the Minding the Baby home visiting program. And just to give you a sort of thumbnail sketch of what this program consists of, it's theory-based, it's evidence-based. We start working with families while mothers are still in their second to third trimesters of their first pregnancies. We use an interdisciplinary team of visitors, both a nurse and a social worker, so we can address health as well as mental health issues at the same time. We have something called reflective parenting as the central focus of this intervention to try and help parents become more aware of their own feelings and thoughts, as well as the feelings and thoughts of their child as that child goes through infancy and into toddlerhood. A focus on health and mental health, and we provide mental health services in the home. Many of the home visiting programs that are currently operating are outstanding, and in particular, the Nurse-Family Partnership that was created by David Olds and Harriet Kitzman, is a very, very strong, rigorously evaluated program, but doesn't have a mental health component as a part of it. And we knew from our clinical work, as well as the literature, that mental health issues were very important in these young families' lives, and especially the lives of the young women. So we knew that had to be part of this work. Just to give you a peek at some of our outcomes, we've been able to really look at and demonstrate enhanced secure attachment in the children of the families who are part of this, less disorganized attachment. I'll describe what that is. Basically better parent-child relationships, less child protective service involvement, and some very nice health outcomes, particularly in young mothers who are able to delay repeat or subsequent childbearing past 24 months in many cases. So this is really talking about prevention at a very, very early stage of a family, as the family is really just beginning to bring a first child into the mothers define who is in their family. So they get to say who's going to be part of this intervention and who's going to be included. And that oftentimes changes over time, but they get to kind of define who their family system is. And consequently, our service oftentimes provides direct service as well as indirect service for at least 2 generations, the mother and the child, but oftentimes 3 generations, because we often include grandparents in this work as well. And this is just a picture that kind of shows some of the ways in which we work with families and what we think are some of the active ingredients of this program. So the ability for the clinicians to work on secure attachment, the mother-child relationship, or in some cases it's the grandmother-child relationship or the father-child relationship. Certainly self-efficacy in mothers is really important. Being able to help them become more reflective parents by establishing a really important relationship with them. So the home visitors really create strong and very positive working relationships. And using a variety of discipline approaches to address the many needs that most of these families have. So why is this important? Why are we doing this? Well, as science continues to understand some of the early and then prolonged effects of stress on children, and then as children grow into adolescents and adults, we know that there's such a thing called toxic stress. We know that there's such a thing called complex trauma when individuals are exposed to ongoing and oftentimes repeated kinds of trauma, both early on in their lives and then later. We know there's a whole growing body of literature on something called adverse childhood experiences that when you have a certain quantity of adverse childhood experiences in your early life, that can be strongly correlated with not only mental health and behavioral outcomes, but also some very real chronic and acute health outcomes in adulthood. And we also know now that there's problems with brain development when children are living in toxic stress environments where they don't have supportive and caring relationships with their primary caregivers. We know that some of our outcomes are likely addressing some of these processes. And what we try and focus on is not so much teaching parents how to do things, how to learn behaviors to take care of their children, how to change diapers, how to bathe them, etc. But we try and focus on something that we think has more staying power, which is how parents understand their child. And that's going to change over time as the child matures and changes. But this is done through this mentalization process and our focus on reflective parenting. This is another way we think about this work. The Minding the Baby team, the supervisors and the clinicians, all work to support and supervise as well as support the individual clinicians who are doing this work, who are going into homes, week after week. The clinician in turn is able to support and hold the mother when she is, going through crises, is going through transitions, and then in turn the mother learns how to hold the child that she is raising. So it's a very nested kind of an operation. The theoretical underpinnings that we rely on for this program, human ecology model, obviously that's sort of inherent. Self-efficacy is important, attachment theory, but this reflective functioning, which is really a framework that comes out of attachment theory, is sort of there, as I said before, very central to what we do. So the ability for parents to learn to understand their own thoughts and feelings and intentions, and then also recognize that their child has unique thoughts and feelings and intentions. So those are the things that are behind or underneath behavior. The programs that we use to design this intervention were, as I mentioned, the Nurse-Family Partnership. We looked at Dorothy Bruton's work and her colleagues on using advanced practice nurses in transitions and community-based care, and then the elegant work of Heineke and Alicia Lieberman in looking at parent-child interactions and therapies, as well as infant mental health. So we use master's prepared clinicians as home visitors, and that's a little bit different from many home visiting programs. And what our feeling is that this is a level of practice and expertise that allows the clinicians to match their practice with the level of need that the families are exhibiting. So there's a lot of developmental and cultural work that's part of this intervention. We work with very diverse families in this community and in other communities we've worked in. And there's a very elegant layering of the practices between the nurse and the social worker, so that there's overlapping and reinforcement and almost like a tag team kind of approach to working with families. And then this is just a diagram that kind of shows a little bit of how we think of this schematically. The nurse focusing on physical care and health issues, the social worker focusing on infant health and infant mental health and maternal mental health, and then a big area of overlap that they both practice within in terms of parenting, the attachment, and the development. So when we start with families, there's a very gentle and long engagement process where families can sort of talk about their own goals and needs, as well as the ability for us to assess their not only problems but their strengths. We start in pregnancy because that's a time in which families feel pretty vulnerable when they're experiencing a first pregnancy or a first baby. So they tend to be more open to new ideas or new ways of doing things. And we try and stay as flexible as possible. Now, I'm not going to go through all of these roles and areas, but as you can see, the nurse, has a lot of areas that she can help families with. And I've just put a few in red to just kind of help them stand out in terms of some of the particular things that we think are very powerful in this work. Helping moms get ready for going through labor. And oftentimes these are young women. The majority of our moms are teenagers, and they've been abused. They've been sexually abused. They've been physically abused. Sometimes we don't even hear about that until later, but that oftentimes abuse and trauma is part of their life experience. And so labor can be a real challenge. And so there's a way that we can do that to help them feel better and get through their labor a little bit easier. Breastfeeding is huge. That's something that we spend a lot of time on. And also with respect to the mother's health, helping mothers look at viable plans of contraception for themselves to prevent them from having another sort of unexpected or rapid subsequent childbirth. Similarly, the social worker has lots of work to do in terms of assessment, diagnosis, various kinds of counseling, and various kinds of therapeutic approaches for parents, for couples, for mother-baby work. So there's lots and lots to do. We try not to refer out when mothers need particular kinds of mental health care, because oftentimes if you make a referral, they don't keep it because they're not comfortable going to see somebody, or there's a great stigma about mental health care. And so that's sort of the beauty of the in-home treatment that we can do. Now, obviously, sometimes there are emergencies or there's need for medication when we do have to work with outside clinicians as well. Okay, so building these reflective capacities helps to enhance mothers' ability to understand their children's behavior a little bit more. And how do we do that? We do this by speaking for the baby, putting words into the baby's mouth. Babies can't speak at this point, so trying to show parents how their babies might be feeling that might be underlying certain behaviors. We wonder, we're curious, we kind of try and engage parents in thinking about how they're feeling, how the baby's feeling, and how those things might be different. As I said before, the relationships are really important in this intervention. And pregnancy is a great time to start, and oftentimes families are very concerned about social workers. They may have had not great experience with social workers in their lives before, and so that's why having a team is really helpful. The nurse can really sort of go in as the less threatening person who's got lots of health information to offer, lots of answers to their questions, and then the social worker is integrated into that team. Okay, so this just gives you an idea of what our program looks like. It's 27 months long on average, weekly home visits, and after the baby turns 1 year, then it's every other week. And generally our home visitors alternate weeks, so families for the most part are getting one visit a week, and it's the social worker and the nurse going back and forth. We use there's a lot of flexibility depending on what's going on with the family. We have a manual, it's a treatment manual, but the clinicians have a lot of room for being flexible, depending on the needs of the family. In terms of enrolling people into this intervention, as I said, we start during pregnancy. We have criteria that we use. And as I said, fathers and grandparents are most welcome to participate if they are sort of named as important people by the mother. This gives you an idea of what happens during the visits, the kinds of topics that are discussed, and a general idea of how the time is spent during home visits. Our work continues to be very collaborative with the community health centers with whom we work. And we feel that this is not only beneficial to the patients and the families, but it's also beneficial for our home visitors who have the ability to work collaboratively with those clinicians on an ongoing basis. So the research that we've done started in 2002. We started with a feasibility study because we weren't sure that families were going to tolerate or be okay with all these home visitors coming into their lives. And so we started small, and in fact, that was not a problem. They didn't get confused, and they welcomed both home visitors into their homes. We followed that by a pilot study and then a larger efficacy testing trial that started in 2009, and we're currently analyzing, as we speak, some of those data from that larger study. I do have a few summary data that I can show you from our pilot work, a little bit of qualitative data from some analysis that we've done with the youngest cohort of young mothers in our program, and then I can talk a little bit about sort of new directions for our research in the future. So currently, the aims are to compare our intervention and our control group on a number of variables that we see in mothers that are important: the mother-infant relationship, infant health, and behavioral and developmental variables, and then we look at the incidence of child maltreatment. And we have lots of measures. We generally are working with families for our research measures. In pregnancy, for baseline, at 4 months, we look at a parent-child interaction. At 12 and at 24 months, we do surveys, and then we also do some laboratory assessment of the parent-child relationship and development in the child. And I forgot to say, and we also are looking at maternal reflective functioning. That's assessed with a semi-structured interview in pregnancy, and then again at 24 months. Our sample that is in our pilot study, we have 105 in total. It's a fairly young sample. All of our families are low income, fairly low levels of education, and for the most part not working outside the home. The majority of our families describe themselves as Latina. Most are not married. And at intake, some of the families are already defined by Child Protective Services as at risk. And this is usually for the parents of the teen mothers have been reported to DCF. So already, there's eyes on these families. In terms of our findings that we have reported, the children are more likely to be receiving regular pediatric visits and be on time with their immunizations at 12 months. A trend towards less child protective involvement in our Minding the Baby families. And an outcome that we're very proud of, which is lower rates of rapid subsequent childbearing in these very young moms. And that's huge. If you can delay a second childbirth until after 24 months at least, there's all kinds of positive outcomes that are associated with that. At 4 months, we see it's only a trend so far in less disruptive communication among the mothers and infants. We see more securely attached infants and babies at 12 months in our Minding the Baby sample. And less, as I said, less disorganized infants. Disorganized attachment is associated with all kinds of behavioral problems and issues, later on in childhood and later on in life. So it's something to be avoided. Reflective functioning levels, as we currently assess them, seem to go up for everybody with developmental experience. But in our highest risk mothers, we saw a statistically significant increase in the mothers in our intervention. So we're seeing some promising results. We're waiting to see what our larger sample shows us. But I think that we are very encouraged and are continuing to try and do this work, keeping the service model going forth and then looking at some other things that we want to study. One of the things that we've looked at qualitatively is what our very youngest moms look like. Can they become reflective? How do they do reflective functioning? And how, what do they look like in pregnancy? And so these are some qualitative, just some initial qualitative findings that we're coming up with. We took the pregnancy interview transcripts that had been coded for levels of RF, and we were blind to those codes, and we just looked at them from a qualitative research perspective. We found some interesting trends in terms of how these girls were feeling and thinking about themselves as potential mothers. So they were being interviewed in their last trimester of pregnancy. They really, we could tell, it came through loud and clear in these interviews, that development made a big difference. How they think about themselves, how they think in general made a huge difference, as did their immediate environment, their family, their partner, and the community, the neighborhood that they lived in. And so some of the things, the overarching things that sort of came through was that this almost universal shock at being pregnant, even though these were by and large people some of whom were planning the pregnancy, and many of whom were not using any contraception. But everyone was shocked to find out that they were pregnant. They really wanted fathers to be involved, but they didn't have great expectations that would, or partners, that would happen. Lots of reliance on their own family members, as you would assume. And many of them had some real concerning hopes, but fears about what it would be like for their child. And this is just an initial sort of way that we're thinking about how this emerging reflectiveness comes through in young teenagers at this early stage of not even being a mother yet, but thinking about being a mother. So these are some quotes, some direct quotes, which I always like to share. I want my children to be able to say, I'm loved so I can love others. Talking about their home visitors, they help you to help you, which I think is kind of self-efficacy in their own words. Monica Warnway has done a follow-up pilot study of some of our families, and just a brief summary of some of her findings is that when children were aged 3 to 5, there were significantly fewer externalizing behaviors reported in the children of the Minding the Baby group. Externalizing behaviors is acting out. That's what gets you kicked out of preschool, and children can run into all kinds of long-term problems. Also a trend for Minding the Baby mothers experiencing less parenting stress at that point in time. So ongoing work. We're going to be adding some biomarkers of stress. And again, this is something that Monica's very interested in, and she's taking forward. We are looking at some other health variables, looking at sleep patterns in some of these families, especially as it relates to toxic stress in families. And then thinking about some longitudinal follow-up for our whole cohort. In the United Kingdom, we've got 3 sites that are implementing a full replication. So they're doing the program as well as a randomized clinical trial. And the trial just started last month, so we're kind of excited to see how that's going. It's been really fun doing supervision and training and orientation across the ocean. The site visiting is really quite fun. And we've learned a lot as we've had to translate this program from a U.S. model into a UK model. Very different systems, very different family situations, and so it's been really a wonderful experience. We've also come up with a training program for people interested in minding the baby. We were getting so many calls about people wanting to come visit us and learn about it that we decided we would just do a training institute. And so we run that every summer where we share our clinical approaches. And this is something that we're going to be expanding as we kind of move into the next phase of sustainability. So we are, as I mentioned before, looking at sustainability. We've got a Donahue Foundation grant to do that and to look at both business models as well as service delivery models. One of the interesting things, I'm almost done, Margaret. One of the interesting things that we had to do in thinking about this business model was who do we pitch this to? And when you pitch a program that is serving, underserved families, one of the things that you have to be careful about is not to describe your program or the community in ways that immediately get linked to negative stereotypes. So we've actually gone through a framing process, which has been fascinating, and they've taught us a lot of things about how we describe what we do, so that hopefully we will get a positive response from policymakers, payers, funders, et cetera. So that's been sort of an interesting thing. Okay, so I just want to acknowledge our funders. Certainly we've received very wonderful and generous funding from NIH, as well as many foundations, and specifically the FAR Fund has been very generous with this work. Forget that, just some references. And then I also wanted to just show how many people have worked on this over the years, how many Yale nurses have worked on this over the years. And then just to finish, to thank you for your attention. Yes?
Yes, ma'am. It's interesting, that you mentioned the total concept of the program is a collaborative, interdisciplinary approach,
Right.
Teamwork, if you will.
Right.
Whereby you're looking at the total person, the total environment.
Right. We try.
Yeah, exactly. As well as the environmental things that would affect
Absolutely.
the health of the baby. Just an observation. I find, and do you agree, that sometimes prior to the actual delivery of the services, but do you find that it would be a short force in cultural awareness to get familiar with the particular environment by which you want to teach or approach? And the reason why I ask that,
For the clinicians, you mean?
yes,
Oh, yeah.
clinicians as well as the entire team,
Mm-hmm.
because as the team is assembled to provide the services, sometimes there's a disconnect. As you mentioned before, framing. Who do you pitch it to? What words do you use?
Right.
We found that in the North Camden Health Center was a series of family practice centers in the neighborhood, very unique at the time. North Camden in particular was 95% Hispanic, and we're just like racking our brains. I mean, everything was going on. Folks needed help. If mortality was out of control, when the rest of America catches a cold, they had pneumonia. So we refused to not serve these folks. So what we found, if you read the wilderness, North Camden, brief history of North Camden, really, the police don't go to North Camden after 4 o'clock. That's it. It's like a whole other world. So we found that the Hispanic community in particular, as well as other communities, they're family-based. People are shy. And so they had negative experiences. So what I needed to do is gain trust.
Right. That's essential.
And you have to.
Right.
You have to listen.
And in response to your question about cultural sensitivity, absolutely that's part of our training and our ongoing discussions. But there's two things that I would say. One is that we've been lucky enough to have some multicultural folks on our treatment teams, which has been wonderful. But we have learned so much from our families and have really gone in most times with an open kind of an anthropological attitude. Teach us, okay, we come from different cultures. Let us know, what's important to you. What are some of the traditions that are important? Why are you doing things certain ways and not other ways? That sort of thing. Because it's always a negotiation. We can't come in and say you must do it this way. It's always a negotiation, and the family members are part of that negotiation, as are the parents. But we've done in formal ways as well as informal ways, asking for that input from the families that we serve so that they can inform the care and inform the providers of care as well as be the recipients of care. So it's I would say it's a very individualized and I think it's a pretty culturally sensitive approach. And we try not to make assumptions because we work with Latina families, but we work with Cuban families, we work with Mexican families, we work with Puerto Rican families, all of whom are very different in their traditions and their beliefs and their ways of thinking about child rearing, about health. So, it's really important for us to know those differences and, even if we think we know what the differences are, not to make that assumption, but always to ask and kind of, have that conversation. So,
bilingual capability?
Some of them do. I mean, that's always an issue, and we wish we had more of that.
Well, I suppose the young people tend to speak.
Well,
Mothers
exactly.
probably,
It's the
grandmothers.
second generation. Yeah, it's the grandparents that oftentimes are not able to speak English. Yeah.
I never thought I'd ask this, but have you done a cost-benefit analysis? I hate that concept because
It's being done now.
Good.
Yeah. Our health economist has the data right now. So he's looking at it. So fingers crossed. Yeah.
Can you say a little bit more about your training institute and how you attract the attention of the international sites?
Well, many of us go out and do talks, in scientific meetings, and my colleagues get invited to do talks. I get invited to do talks. We present abstracts, etc. So what we find is that, after somebody has gone and done a talk or a publication has come out, we get inquiries. In terms of the collaboration with the United Kingdom folks, that actually happened because of somebody heard a talk and then got in touch with us, and the National Society for the Prevention of Cruelty to Children, which is kind of a morph between Child Protective Services and a service provider to prevent child abuse. They were in touch with us and they came to our training. Several of their CEO and their supervisors came to our training and decided that they wanted to give this a try because what they were doing at that time was not sensitive to very young children, and they really liked this mentalization approach and the fact of dealing both with health and